You can start.
Madam, I'll set up the laptop. I think so. She's moving on to my room. If it is getting delayed, can Kavya present first or?
How long she'll take?
She's just on her way, ma'am. She's on third floor. She's coming over to fifth.
Reshma,
Ma'am.
hi Reshma. Will Kavya will be able to start this?
Definitely, she'll be able to start, ma'am. In a minute, I'll give a quick call to Bhanu, who's the other moderator, ma'am. Meanwhile, she can start, ma'am. Not a problem. Kavya can start.
Okay.
You can start.
Yes,
Just open up, connect here. This is the password. She came up. Otherwise, yeah.
ma'am. Kavya can start or?
She's joining. Okay. Connect.
Am I able to share the screen?
Yes, Anisha, should we start with yours or?
She joined. She's connected. She's joining the Zoom. Let me see if she's able to share her. Is yeah.
Recording in progress.
Anisha, it's better to have the audio from hers only, I think. No? If you switch on your audio, there may be echoing. Okay. Vaishnav,
Yes,
you can
ma'am.
stop sharing. We'll just introduce and then you can start sharing.
Sure, ma'am. Sure, ma'am. Okay.
So Reshma will start with Kim's only and then we'll take up yours.
Sure, ma'am. Okay.
Yeah. Welcome everyone to this IL Academy Autoimmune Disorder Subsection. So we are having case discussions which are going to be there with alternating with debates. And eventually we'll be starting journal clubs. So we already started the case discussions last month. And this is the second case discussions. This is going to be both from two hospitals from Hyderabad. One is from the KIMS hospital and followed by NIMS. So from the pattern and the format is going to be the same. 5 minutes for the presentation. And then there is going to be discussion with the attendees and the panelists. So I request the attendees who are there to post their questions and their queries onto the chat so that it can be taken up. And then we will have an analysis and then come to the diagnosis, which will be done by the discussant. So that is the format which will have each of them half an hour. Okay, so we start with KIMS Hospital. So the presenter is Dr. Vaishnavi, who is a DMB resident from Gandhi Medical College, Secunderabad, currently pursuing DNB Neurology at KIMS, Secunderabad. And the discussant is going to be Dr. Anuja Patil, who is a consultant neurologist at KIMS, Secunderabad, who has also done MD from KM Mumbai, DM from PGI Chandigarh, and PDF in epilepsy. So we start with the case. Over to you, Vaishnavi.
Thank you, ma'am. Good evening, everyone. Is it visible, ma'am?
Yes, yes,
May I start?
yes.
Good evening, everyone. Today's first case discussion. It is about a tale of two sisters, refractory familial encephalitis. So first, we will see about the first sister. So she was a 20-year-old lady with no significant medical history. On day 0, she presented with fever and headache. This fever and headache was followed by, on day 2, she had altered behavior in the form of she couldn't recognize her parents, and her parents also noticed that she was wearing her clothes improperly, that is, inside out. So, with these complaints, she was taken to a psychiatrist in the locally, and she was treated with antipsychotics. Despite which, they have noticed that on the day 3 and day 4, there was a sensorium worsening with seizures, which landed her finally into refractory status epilepticus. So, with these, she was taken to a local hospital, she was admitted there, and she was intubated. Then, she was evaluated with MRI, which was normal. And because there was a history of fever prodrome followed by an altered behavior, that is psychiatric disturbances, with new onset seizures, they have thought in terms of autoimmune encephalitis, and CSF autoimmune panel was sent. And eventually, NMDA antibody came out to be positive. So, in view of autoimmune etiology, she received 5 doses of pulse IV methylprednisolone, following which, on day 7 of admission into the hospital, rituximab was given. However, uh, even after giving first line and second line dose of immunosuppression, she never regained consciousness during the hospital stay. And after 40 days of hospitalization, she succumbed to her illness, likely secondary to sepsis or continuation of the status epilepticus. So this was the brief history of the first sister. Then 6 months later, coming to her second, that is our second case, that is her younger sister, who was 19-year-old at the time of presentation with no significant medical history. She was brought to our hospital with complaints of, she also had a UTI followed by vomitings. So she was taken to a general physician and she was treated with antibiotics. Later on, almost 4 or 5 days later, mother noticed that she was having the same behavioral abnormalities in the form of irrelevant talking, and she was sending messages on phone to her dead sister. And mother also gave the history that she could see her elder sister walking in front of her and talking to her. Simultaneously, they also noticed that this lady had multiple episodes of left focal seizures and 1 episode of BTCS. Immediately, she was taken to a local hospital and then she was referred to here. When we received her in the ER in the midnight, the patient was afebrile, irritable, and could not follow complex commands. However, physical and neurological examination did not reveal any pathological features. We have reviewed her MRI, which was taken elsewhere. A plain and contrast MRI did not reveal any significant abnormalities. Because she was very irritable, afebrile, and she was having continuously left-sided focal jerks, an EEG immediately was done, which was showing a right-sided hemispherical slowing with superimposed fast activity suggestive of an extreme delta brush pattern. Because she was following the same clinical course as that of her elder sister, and fever prodrome followed by psychiatric disturbances and new onset seizures, autoimmune etiology was thought, and CSF analysis, along with, because she had a viral prodrome followed by seizures, so viral encephalitis versus autoimmune etiology was thought, and CSF analysis was done, which showed mild pleocytosis with WBC of 10 with 95% lymphocytes predominance. And PCR for herpes simplex was negative. Meanwhile, with a strong suspicion of an autoimmune etiology, CSF autoimmune panel was sent. And these are the criteria given when to make a diagnosis of encephalitis. So in our case, it was subacute onset. She had an altered mental status. She had psychiatric symptoms. She did not have any previous history of epilepsy or seizure disorder. And CSF showed pleocytosis, but MRI did not have any features suggestive of encephalitis. But we had not all features, but few features which were suggestive of autoimmune encephalitis. So with a background of autoimmune encephalitis in the elder sister and with the similar presentation in her, we have admitted her to ICU and started her on IV antiseizure medications and IV methylprednisolone 1 gram per day for 5 days. Simultaneously, because she had worsening of clinical symptoms in the form of dyskinesias involving her left upper limb and face, seizures, and new symptoms of neologisms, mutism, and dysautonomia, we immediately, simultaneously, we also got a CSF autoimmune panel, which was positive for NMDA receptor antibody. Simultaneously, workup was going on and PET was done, which showed hypermetabolism involving the right insula, right frontotemporal region, right lateral temporal, left cerebellum, and also hypermetabolism in the left parietal lobe, which is actually explained in the clinical picture. So immediately, we know that anti-NMDA receptor antibody encephalitis was associated with ovarian teratoma. Then ultrasound MRI pelvis was simultaneously done. But we did not, basically, you're searching whether we can find any ovarian teratoma. We could not find any. An indirect search for teratoma in the form of tumor markers was done, which was also negative. And in view of strong family history, HLA testing was also done. And HLA DRB1 1502 was found to be positive. And simultaneously, because our clinical course was worsening, we immediately escalated the treatment to a second line of immunosuppression, that is rituximab. So we have started her on 500 mg of rituximab weekly. So she received total 4 doses of 500 mg rituximab, which was started on day 3 of admission simultaneously along with IV methylprednisolone. Later on, this rituximab, after completion of rituximab 4 doses, she was put on oral immunosuppression in the form of tablet MMF, which was initially started at 500 mg twice daily for 2 weeks, followed by 1 gram twice daily. Despite which she continued to have facial and limb dyskinesias with intermittent aggressive behavior and inappropriate smiling. However, we now notice that after starting of second line and also with MMF, little favorable outcome was there, but in the form of she was able to at least accept oral feeds and communicate in bits and pieces with the family members, although with frequent irrelevant talking. So in these 2 videos, we can see that initially she was mute, but we can see that the left upper limb is into a dystonic posturing with intermittent dyskinesias being happening. She could briefly answer only just her name. Apart from that, we could see that she was irrelevant, not very coherent. Then this was happening. So she stayed with us almost for 50 days. And this course was slowly, she did not get back to her baseline. But however, her progress was slow. Like the disease progression was relatively stable. So we have informed the parents regarding the nature and prognosis, and she was shifted to a rehabilitation area. Then, after 20 days of discharge, she again presented to a hospital with similar symptoms. So, multiple episodes of left focal jerks, left upper limb dyskinesias, irrelevant talking, and poor food intake. So, we immediately admitted her and we performed an EEG. So, this EEG, we can see that it was suggestive of we could record a seizure with ictal onset in the right hemispherical ictal onset, which was which was evolving in terms of frequency and amplitude, with some amount of left temporal chain spread as well. During which period the patient was actually mute and was not responding to her mother, asking repeatedly to answer her name. So the same thing, EEG was suggestive of right hemispherical ictal onset with evolution in frequency and amplitude and spread to a left temporal chain. So already we have completed the second line of immunosuppression, but disease was relentlessly progressing. So then we thought we'll escalate it to the third line. So then she received injection tocilizumab 500 mg, 8 mg per kg infusion monthly. So she received total 5 doses of tocilizumab. Following which we have noticed that her dyskinesias, seizures, and her able to communicate with parents and perform her ADLs significantly improved. So this happened over the next 5 months that with each dose of tocilizumab, we have noticed gradual improvement in her clinical condition. So gradually her anti-seizure medications are also tapered and stopped. Then after completing 5 doses of tocilizumab, we repeated a PET-CT brain to look for any ongoing activity. We could see that the changes have reverted back completely. And currently at the latest follow-up, that was 1.5 years into the illness, now we can see that she is symptom-free and she's attending her college, and recently gave us a very good news that she has been placed through campus placements and she's currently off any medications. So this is the same girl that we have treated. So this is a final thing. We can see that she is very happy in her life. She's very much back to the baseline and completed her college and as normal as any other girl would be in her age. So thank you.
Thank you, Vaishnavi. Just wanted to know a few things
Yes.
about her follow-up. What happened to her NMDA in follow-up? Was PET MRI repeated, or any other workup for malignancy was done in the follow-up after 1 year and 1.5 years? Or
Ma'am,
what
at the
happened?
follow, yes, ma'am. At the follow-up, the PET was repeated, ma'am. That is after 5 doses of tocilizumab. The second PET, which I have shown, is the consequent PET, where the signal changes have completely resolved. But apart from that, we did not repeat any CSF or NMDR antibody titers, or we did not repeat any screening for ovarian teratomas, or any tumor markers were repeated, ma'am. So we relied on the clinical symptoms as well as the PET for resolution of her disease activity.
Okay. Serum NMD also was not repeated.
No, no, ma'am. No, ma'am.
Okay, thank you. I'm not sure whether a similar case, I think Dr. Sita Jayalakshmi had presented long back, I think some 2 years back, about a familial case of NMD encephalitis also in one of the IM webinar. So I request the attendees if they have any observations or queries. Just one other concern was there.
Yes.
Both of these patients, there was steroids was given and then rituximab was given. Do you people believe in the role of plasmapheresis in the acute period?
Madam, in our setting, ma'am, we generally are not preferring plasmapheresis for our local, basically, ma'am, Plex is not preferred over methylprednisolone or second line of management, ma'am.
No,
So we had
it is not that it is preferred over methylprednisolone. It acts in conjunction with methylprednisolone. So there are the schools of thought is NMD is supposed to be a pathogenic antibody. So when it is pathogenic, basically what happens is the more you have the NMDA being secreted, it also causes a lot of abnormalities, neuropsychiatric problems. So one of the thing is the use of plasmapheresis. It helps in two ways. One is it removes the NMDA. The other is it also modulates the immune system, and the inflammatory markers and cytokines are also modified. So it helps in both the ways.
yes, ma'am.
I know many places do not believe in plasmapheresis, but I think we have a very good, robust transfusion medicine specialist as well as a very good blood bank. So we do believe in plasmapheresis, and we have seen that there is definitely a difference when plasmapheresis is given, because both of your patients, one of them was fatal, one of them required multiple immunotherapies.
Yes,
So that
ma'am.
was one of the reason I suggested about usage of plasmapheresis.
Yes, ma'am.
I think we don't have any queries in the Reshma, you want to tell anything?
Most of my experience is from so I think plasma exchange in our center we are doing it in conjunction with IV methylprednisolone, and the results have been exceptionally good. Whatever follow-up we have of patients who are having the receptor antibodies, not the intracellular antigen-mediated antibodies, but the surface receptor antibodies, they respond exceptionally well to plasma exchange. So whenever we come across patients with NMDAR, we do not delay if the presentation is very severe. We start them with IVMP and Plex, because by doing Plex in the first place, we'll always have that window to treat with IVIG later if they are not responding very well. So that is what we are following in Nizam's.
Yeah. I know many places I've seen that Plex is not being used very efficiently, but it is one of the very good treatment option which is there. And not everybody will be able to afford higher medications, rituximab and tocilizumab.
The only concern here, ma'am, like for people who have like NMDA, as it progresses, dysautonomy, everything comes in. So while on being on steroids also, the only concern why maybe the approach towards plasmapheresis in our setup also, sometimes the like complications associated dysautonomia or sepsis related, especially
No. In fact, that is the thing I just want to reiterate. Many people think that plasmapheresis is some very difficult procedure which will cause autonomic dysfunction and many other things. No, it's a very safe procedure if it is done well. In fact, we have many of our ICU patients who have dysautonomia and who have been treated. Of course, we'll have to monitor the blood pressure changes. Sometimes when you do it too aggressively, you can develop a hypotension and things. But still, it is a very good therapeutic option. And it in fact, comes down on your this one. I think there is a very good novel on NMDA, autoimmune
renal
encephalitis
fire.
about brain on fire. So it's
Renal.
exactly that. So when you have the fire, you need to put all your armamentarium into action to see you that you see that the fire is put off. And the plasmapheresis is one of the very good therapeutic option. I know many hospitals do not do that because of multiple reasons, but I just want to reiterate that wherever the options are available in whichever settings, I think that should be given before we think of IVIG and rituximab. Dr. Gerti sir, you have raised your hand?
Yeah. Can I talk?
Yes, sir,
Good
please.
evening. The plasmapheresis, one thing is sure that you are going to remove the antibodies.
Yes. Yes, it actually helps removing the antibody because by now we know that there are few antibodies which are pathogenic like aquaporin and they're all pathogenic antibodies, even ACHR. See, these
I
are all
had
pathogenic.
encountered thrombosis of the vessels. That's a major complication which we had, and hypocalcemia, the second one. So these are the others are. No. I think it's a safe procedure. I agree with Dr. Netravaj. We should also consider this whenever is available. IVIG is very costly when compared to 5 lakhs or 4 lakhs, and within I think 1 lakh you can complete this procedure possibly, and that's what I feel.
Yes, sir, true, sir. I think Vengama ma'am, do you want to? Asmita Vengama ma'am has a comment. Could you unmute her, please? Is Madam unmuted? I think Madam has raised a very valuable comment about people who have bortezomib. I think that is what Madam is trying to comment, that this also they have used. They have also used in few patients and found to be helpful. Thank you, ma'am. Vaishnavi, one of the Dr. Arun Kumar has asked one question about how common is normal MRI brain in NMDA encephalitis.
Yes, ma'am. So usually we see that MRI is less than 50% cases. It is usually normal, and people with normal MRI tend to do well compared to people with MRI changes, ma'am. Usually MRI changes are seen in 50% of the cases, ma'am. NMDA
Yes.
are antibody positive cases. Yes.
Yes, 50 to 60, and some we also say 60 to 70. In fact, 30 to 40% of the MRIs are abnormal in an Indian encephalitis. And as you said very rightly, abnormal EEG, abnormal MRI persisting are bad prognostic factors.
Yes.
And especially if you have a HSV triggered autoimmune encephalitis, MRI is always abnormal.
Yep. No.
That is
Yes.
the other thing. Okay. So if there are no other comments, Dr. Anuja, you would like to take it forward?
Yeah.
Yes.
If the slides are visible, I'll start.
So you have to put it in slideshow.
Yeah. This is in slideshow right now. Okay, just a sec. I'm putting it in slideshow. It is coming on my screen, ma'am.
Asmita, can you help us? Digital team, anybody? Asmita?
Open it in yours. Hello, ma'am. Can Dr. Vaishnavi share her screen? I'll present it from that laptop itself.
Yeah, you'll only have to log in. You have to stop share.
Sharing.
Yeah.
It's coming up.
Vaishnavi, it's your slides, I think. It's not Anuja's slides, it's your slides. Yes, it's seen now. Yes, Anuja, you can go ahead.
Yes, ma'am.
Hello. Are the screens visible, ma'am?
Yes.
Yeah. So just to put it in a nutshell, our this case was a 20-year-old girl who had presented nearly 6 months after the demise of her elder sister succumbed to the same illness of NMDA encephalitis. This girl did have waxing and waning course of illness, behavioral disturbances, dyskinesias, mutism, seizures over months, and despite the initial first line of therapy with methylprednisolone rituximab, additional MMF initiated in quite an early stage. Still, she continued to progress. Following initiation of her escalation to the third line immunotherapy of tocilizumab, finally showed the remission and resolution of symptoms to her baseline. So, which brings us to the clinical questions. How far does positive family history contribute to pathophysiology of NMDA encephalitis? Early initiation of immunotherapy is crucial. So, how soon to initiate the second line therapy? And when the routine immunotherapy fails, when is the right time to escalate? Just to have a brief overview about the disease, back in 2025, nearly two decades from now, Vitiliani et al. Had described the syndrome, and it took nearly 2 more years for the actual antibody to be isolated against NMDA receptors. The syndrome per se spans across all ages, and female predominance is noted before 45 years of age, following which, however, there is much of a balanced sex distribution. A typical course does show a viral prodrome, following which there is escalation of syndromes to say, psychiatric disturbances, sometimes seizures, in progressing to almost status epilepticus, movement disorders, particularly orofacial dyskinesias, disturbances of autonomic dysautonomias, sometimes causing hypothermia or central hypoventilation. The pathophysiology per se, classically described in association with ovarian teratoma, or as also Madam had told about HSV precipitating or triggering the NMDA encephalitis. Whenever virally transfected cells or neurons from the ovarian teratoma release these antigens into the circulation, they are segregated by the local lymph nodes. Here, the naive B cells are triggered or sensitized to these antigens, which start producing antibodies. What makes this syndrome unique among all the other autoimmune encephalitis are these antibodies preferentially bind to the open synaptic or the extrasynaptic NMDA receptors. So the particular subtype of the antibody being IgG1 or sometimes IgG3, which causes internalization of the NMDA receptors, causing reversible synaptic dysfunction rather than neuronal cell death, which is seen commonly among the intracellular paraneoplastic encephalitis. Brings to our clinical question over today's case: what triggers or contributes to this autoimmunity induction? There has been evasion of self-tolerance due to faulty KIR signaling. So, genetic predisposition, familial autoimmunity, are these the predisposing factors? Environmental triggers or epigenetic modifications of the NMDA receptors, and how far these contribute to the response to immunotherapy? Genome-wide association studies have found out like NMDA encephalitis is associated with certain haplotypes, frequently associated with these cases compared to the controls. Compared to VGKC or anti-Iglon 5 encephalitis, these haplotypes are quite non-homogeneous and vary across different ethnicities. Our case had HLA-DRB1 1502, which was described initially in Thai population as well. KIR, that is killer cell immunoglobulin receptor modification or polymorphisms, can affect the immune checkpoints and via that immunosuppressive functions, thereby evading the self-tolerance and precipitating an illness. Likewise, epigenetic modifications can influence the expression of NMDA receptor subunits and affect response to routine immunotherapies. On literature search, we did find two other case reports, one among brothers suffering with familial VGKC encephalitis, and another one similarly anti-NMDA encephalitis noted among two siblings 9 years age apart. This brings us to a question whether, like other autoimmune systemic disorders like SLE or autoimmune thyroiditis, does NMDA also have a predisposition familial autoimmunity? This does merit high index of suspicion while screening siblings of kids suffering from NMDA encephalitis when they present with any similar neurological stigmata at least. This is a wide case analysis literature review which spans from case series and case reports described right from 2010 till 2021 of Indian cases of NMDA encephalitis. And like HSV, Japanese encephalitis, or Treponema pallidum, which was described worldwide, Indian cases have shown presence of leptospira, Mycobacterium tuberculosis, Salmonella, or even dengue as one of the triggers. In our case, both the sisters had developed encephalitis syndromes nearly 6 months apart, following a similar febrile prodrome, although the pathogen ideally was not isolated in this case. There are multiple biomarkers like imaging, brain MRI, PET, or even the antibody titers in CSF or serology, which do predict the severity of the disease or in the follow-up of the patients. However, we still lack any specific biomarkers which can predict particular response to immunotherapies or a future chance of relapse. There are new potential prognostic biomarkers reported, the cellular cytokine or chemokine levels or cell surface biomarkers also. Presence of high levels of these potential biomarkers are more likely to be linked with poor response to immunotherapy. The first line immunotherapy, as was rightly discussed also, high dose steroids with and concomitant use of IVIG or plasmapheresis in the right settings is the first line, following which induction with commonly used rituximab or cyclophosphamide is tried, and potentially useful other alternatives for further immunotherapy include tocilizumab, methotrexate, or bortezomib. In particular, targeted therapies like B-cell depleting rituximab has shown promising result, and that has seen nearly double the usage of rituximab in treatment of NMDA after 2013. Corticosteroids have been reportedly shown faster and better response among IgG4 mediated encephalitis or disorders like VGKC or LGI1 antibody encephalitis rather than NMDA. And as we had discussed earlier also, rationale for using plasma therapy or IVIG along with simultaneous use of immunomodulators, because bulk removal of immunoglobulins triggers increased lymphocyte proliferation, which makes them further susceptible for concomitant use of cytotoxic therapies. Outcome-wise, nearly two-thirds, in Indian literature also, nearly two-thirds cases had made recovery to near baseline neurological function. And predictors of good outcome include young age at presentation, a better MRS at the onset, milder symptoms not requiring any ICU admission, and earlier initiation of immunotherapy, preferably within first 1 week after the onset. Fall in antibody titers at 1 month of therapy initiation is predicted to be predictor of a good or better outcome. What about those cases which fail all this? For those, although NMD encephalitis is an antibody positive syndrome, multiple other pathogenic mechanisms also contribute. Particularly the subtypes of immunoglobulins, cytokines, or cell-mediated cytotoxic can play an additional role. And therefore, alternative search for therapies targeting maybe plasma cell depleting agents, cytokine-based drugs like tocilizumab, or treatments targeting intrathecal immune cell depletion like intrathecal methotrexate can be utilized. The earlier, the sooner, the better. But still, even the guidelines, both British best practice guidelines or the international consensus does suggest first line therapy to be used for at least 2 to 4 weeks, and failing any neurological response, at least second line therapy to be escalated. And for cases who have failed or shown any clinical worsening despite a month or 3 of adequate cycles of rituximab with or without cyclophosphamide, escalation to tocilizumab may be considered. But yet, in my personal opinion, at least the sooner the better, especially if the case is contributing with any other, like lack of any other complications apart from this autoimmune encephalitis. So coming to conclude, although rare familial occurrence is possible, early diagnosis with aggressive immunotherapy is crucial for long-term outcome. In cases which are refractory to rituximab, other options need to be explored at the earliest. Close monitoring for further recurrence of symptoms is necessary. Regarding future directives, genome-wide association studies to establish correlation between genetic predisposition to developing predisposition to developing autoimmune encephalitis needs to be considered, and available clinical biomarkers like IL-6 or 17 levels, cell marker levels in CSF need to be explored to predict early signs of relapse or potential immunotherapy agents to be considered in a person, because personalized immunotherapy protocols based on subtyping of antibodies or patient-specific immune profiles may be a way to future at least. So I open this to the discussion.
Thanks, Anuja and Vaishnavi, both of you. So, very true. You brought about the literature review very well about the autoimmune nature and the genetic predisposition. So, just to reiterate few things, yes, autoimmune encephalitis is an acquired disorder. It is not at all a genetic disorder, but we should remember two things. One is a genetic susceptibility. It is not a hereditary disorder, but it's a genetic susceptibility. So, the susceptibility can be because of two things. One is the HLA, as you brought about the HLA haplotype. And other thing is called as a monogenic autoimmune disorders like AIRE mutations, I think autoimmune regulatory mutations. These have been found to be in many multiple polyendocrine diseases whenever it is there, especially with SLE, Sjogren's, VGKC, autoimmune, NMDA. I think these are there. And the second question, what you brought about till when should you be giving the immunotherapy? I know that most of them feel that 2 to 4 weeks, you give one and wait for 2 to 4 weeks. But we always believe that once you find that there is an upward trend of the illness, until you find that upward trend is not shifted to a downward trend, you keep on hiking up your medications. You don't wait for days or weeks to hike up your medications. And yes, nowadays with all the available medications, rituximab, tocilizumab, bortezomib, anakinra, these are all coming in a big way. But I just want to just tell cyclophosphamide. I think Reshma will also remember the patient. We've had many patients because at least in our setting where people can't afford. So we have used cyclophosphamide and we see that they are very good response because with time we have now all shifted to newer immunotherapies and we are forgetting the older immunotherapies. Cyclophosphamide is very toxic. It's over time it is having mutagenic potential. It has lot of bad. It is teratogenic, mutagenic, causes a lot of infection. But for the acute period, there is no harm in giving 1 or 2 pulses of cyclophosphamide also. Apart from what you said, I'm just adding what can be done also in a resource poor setting, especially in places where we have very poor economic status over there, also cyclophosphamide can be used. I think that was a nice overview you brought about the even about the infections triggering. I think we should be aware. Most of us know about HSV triggering, but you also brought about other infections which can trigger NMDR, and we should be aware. Even scrub typhus, that is very common and endemic in many of the states in India. Sorry, so that is one thing which is very less reported, but it is one of the triggers for autoimmune encephalitis. We should remember that also. Anyone else has any comments?
If I may, madam.
Yeah.
Just like for cases which had the seizures or so, directly moving on to refractory status epilepticus or so, here monitoring for the clinical response is quite easier. Either we have the CEG or clinical like observations. But patients who present with just like mutism or behavioral issues, catatonia or so, here it will be like what way we say that they are responding or so. If they continue to plateau around, will that be also a chance or say indication to escalate the clinical therapy? Or
See,
will wait.
mutism and catatonia, I think it depends on who sees the patient first. We neurologists may label it as mutism and a psychiatrist may label it as a catatonia. But of course, it's a very gray area. Both can coexist. One thing is, one of the clinical marker is the mutism should not be as a plateau. Because those are all very core clinical symptoms of autoimmune encephalitis: stereotypy, mutism, and any psychosis or behavioral change. Like, for example, if you are seeing that patient is continuing to be having Parkinsonism or mutism or psychosis, you should find it becoming better. It should not, you don't think that it will plateau and be at the same level. No, it should become better. I think whether it is seizures or anything else, I agree. You said about what you can have when you don't have a marker for the neurological problems. How do you assess? So it is about improvement. They should go back to your baseline. You showed in the second patient how nicely she's become to come to baseline. That is because you went on hiking up the immunotherapies. That is the reason she could come back to baseline. So you should see that trend towards coming to baseline to tell that there is an improvement. As I told, it should not be upward or a plateau. You should see a downward. Uh, Dr. Kirtika has asked about what are the infections for preceding NMDR. Treponema and Lyme's, we remember. I think Anuja put up the slide. There was one slide where she put up all the infections which can be triggering autoimmune encephalitis. I think that was done.
That was a nice AIN review, madam. So
Yeah.
this is a like literature review of our like Indian cases. I think they can refer this AIN review for literature review of NMDA cases from India.
The other thing is sometimes it becomes difficult to list out which infection. By the time patient comes to us, we may not be having all the modalities to test the infection also.
True.
Yeah. Okay. Thanks a lot, Dr. Vaishnavi. Very nicely you brought about the cases, including the videos to show us. Thanks, Dr. Anuja, for giving a very good literature review. Thank you.
Thank you, ma'am.
So
Thanks a
now,
lot.
yeah, thanks. So now we move on to the second case discussion from NIMS, Hyderabad. Asmita, can we have this CV slide, please? Yes. So the presenter is going to be Dr. Akshin Kavya Lahari. She's a DM Neurology Senior Resident at NISAMS, Hyderabad, who has finished her MD from Kurnool and is doing DM presently at NISAMS. And the discussant are going to be Dr. Reshma. Dr. Reshma, she's an Assistant Professor of Neurology in charge of neuroimmunology at Nizam's Institute of Medical Sciences, who has completed her MD from Osmania and DM from NIMS. And the other discussant is Dr. Bhanu Prasad. He is Assistant Professor of General Medicine in charge of infectious disease from Nizam's, who has completed MD and DME from CMC. Over to you, Kavya.
Am I audible now?
Yes. Only slideshow has to remain.
So good evening, everyone. Today we are going to present an interesting case where when symptoms deceive, whether it's an infection or immunity. This is 28-year-old gentleman who is resident of Kannur, literate and a right-handed individual. He presented with complaints of hearing disturbances since last 4 months and slurring of speech since last 2 months. History of hearing disturbances since last 4 months, which are gradually progressive, bilateral, with right ear more affected than left ear. Initially, patient had difficulty to hear the distant voices, now unable to hear the voices which are present nearby. Patient is unable to discriminate both female and male voices. There is no history of increased loudness after particular intensity of sounds. Not associated with any ear pain, ear discharge or tinnitus. Now, the patient is unable to hear anything on the right. Patient had no vision disturbances. History of speech disturbances since last 2 months. There is decreased clarity to the speech and patient is talking syllable by syllable with occasional overriding of syllables. There is no expressive quality to the speech. There is no nasal twang or no hoarseness of voice. No history of any weakness of limbs, sensory disturbances, and bowel and bladder disturbances. No history of fever, trauma, seizures, or altered sensorium. No features suggestive of connective tissue disorders. There is history of animal handling, but there is no history of any drug or toxin exposure. No other family members got affected. With this complaints, patient went outside, where patient was given 1 dose of IV pulse steroid. The possibilities that we consider at the end of the history is chronic progressive sensory neural hearing loss with mixed type of dysarthria. The possible clinical localization is nuclear and intranuclear eighth nerve involvement along with corticobulbar fibers, with possible localization being brainstem, cerebellum and its connections. And etiological possibilities that we considered include inflammatory conditions like sarcoidosis, Sjogren's, neurobiasis, MS, and vasculitis like Cogan syndrome, Suzak syndrome, and others. Infective etiologies like brucella, Lyme's disease, syphilis, tuberculosis. Neoplastic conditions like brainstem gliomas or lymphomas, and metabolic with a remote possibility of mitochondrial was considered. Examination of the patient. Patient is conscious, coherent, and obeying commands. There is no pallor or lymphadenopathy, no stigmata of CTD noted, and no TB disease elsewhere. Language is normal. Speech showed mixed dysarthria with both components of thoracic and cerebellar noted. MoCA is 29 out of 30. Patient fundus and retinal examination is normal. There is bilateral gaze-evoking nystagmus noted with hypokinetic saccades. On eighth nerve examination, on Rini test, there is no perception in the right ear, whereas in the left ear, air conduction is better than bone conduction, and Weber is lateralized to left ear. ABC is decreased in both the ears, suggestive of bilateral sensory neural hearing loss with right ear more affected than the left ear. There are decreased movements in the tongue. Rest of the cranial nerve examination is normal. Motor examination is normal with power 5/5 with intact reflexes and bilateral plantar being flexor. Sensory examination is normal. Cerebellar signs, there is bilateral gaze-evoking nystagmus and scanning quality of the speech noted. There is impaired finger nose test and finger nose finger test, and heel, knee, shin test impaired bilaterally, more affected on the left side, and impaired tandem walking noted. Meningeal signs are negative. So the possibilities, in addition to bilateral sensory neural hearing loss and mixed dysarthria, patient had in additional cerebellar signs noted. The possible etiology of mitochondrial has been ruled out. Investigations of the patient. Labs were sent where the complete hemogram is normal with HB of 12.6. LFT, serum electrolytes, renal function tests are normal. ESR of the patient is 20 millimeters per hour. Serum lactate is normal. Viral screening is negative. CSF analysis was and twice at NIMS, where the CSF analysis which was done in February 2025, it was showing 30 cells with 100% lymphocytes and glucose is 39, protein is 204. CSF was repeated at NIMS on April 3rd. Patient did not have CSF. So the CSF analysis was done on April 3rd, 2025. CSF did not have any cells, but the glucose remained 40 and protein is elevated. CSF repeated on April 24th. The cells are 20 cells with 100% lymphocytes. The glucose is 36 and protein is 284. The CSF opening pressure is 22 centimeters of water. CSF OCPs were sent. There were 4 with type 2 bands being noted. So with the possible CSF analysis, infective etiology was considered more likely with above CSF picture. This is the neuroimaging. These scans were done in February 2025 outside, where we can see flare hyperintensity noted in the left frontal region and left subcortical and deep white matter. And also there are flare hyperintensities noted in bilateral anterior temporal lobes. This is the contrast imaging of the patient, where we can see there is no contrast enhancement and there is no leptomeningeal enhancement or other any brain parenchymal lesions. Scan was repeated in NIMS. This is a scan that was done in April 2025, where we can see there are increased hyperintensities noted in the left frontal lobe. These are the magnified images where we can see there are increased hyperintensities in the left frontal lobe and new subcortical white matter hyperintensities. Also, new flare hyperintensities were noted in the external capsule and insular region. Also, the hyperintensities in the bilateral anterior temporal regions has become increased, where we can see there is confluence of hyperintensities noted in bilateral anterior temporal lobe regions. In brainstem MRI, we can see flare hyperintensities noted in the midbrain region and also hyperintensities noted in the bilateral cerebellar hemispheres and superior cerebellar peduncles. This is the GRE sequencing of the patient, which is showing no blooming. As we consider the possibilities of inflammatory etiologies and infective etiologies, we have sent the workup for the patient, where the vasculitic profile is negative, serum and CSF, NMO and MOG is negative, CSF OCPs were sent, they are positive. Considering infection, Lyme serology was sent, it is negative. Brucella antibody IgM is negative. Whereas serum Brucella antibody IgG by ELISA technique, it is positive. The normal titers is less than 22, but the patient had got a titers of around 93. CSF Brucella serology is negative. CSF VDRL was sent, it is negative. Gram staining in CSF, TB culture in CSF, gene expert ultra in CSF is negative. CSF Brucella cultures were sent, they were awaited. Pure tone audiometry of the patient was done, which is suggestive of bilateral profound sensory neural hearing loss. VEP and SSCP was done, it is normal. The Barrow of the patient is abnormal, where we can see there is in the left side only Weyman is recordable, whereas on the right side there is no recordable potentials noted, suggestive of both cochlear and retrocochlear pathologies. The differential diagnosis that we considered are infections and inflammatory conditions, where the possibility of brucellosis was considered. The points favoring the diagnosis include there is history of animal handling with bilateral eighth nerve involvement, and the CSF of the patient is showing low glucose levels with elevated protein. Serum Brucella IgG antibody is positive, and MRI of the patient is showing white matter changes. But the features that are contradicting the diagnosis is there is no history of any fever or no systemic involvement. With only single value of serum Brucella IgG, we need to repeat the titers 2 weeks later, where we need to see whether there is any rise in antibody titers. Also, false positive Brucella antibody may be possible. Other infections that we considered include Lyme's disease. The patient can have similar presentation, but there is no history of any tick bite or rash, and the Lyme's antibody that was sent is negative. Other infections are viral infections like CMV infections, varicella infections, EBV, retroviral diseases, and hepatitis infections, and bacterial diseases like syphilis and TB can have similar presentations, but the CSF biofile that was sent, it is negative. CSF VDRL and TB workup was sent, it is negative. Considering inflammatory conditions, the vasculitis like Cogan syndrome and Suzak syndrome was considered with progressive sensory neural hearing loss, but patient did not have ocular symptoms and the ocular examination is normal. Patient never had the symptoms of altered sensorium or encephalopathy. With young male with brainstem involvement, possibility of neurobiases was also considered, but patient did not have any recurrent oral or genital ulcers or no other ocular disorders. Systemic vasculitis like SLE, GPA, Sjogren's can have similar presentation, but patient did not have any features of CTD, and the vasculitic profile that was done, it is negative. Granulomatous etiologies like sarcoidosis can present with subacute progressive sensory neural hearing loss, though the cranial nerve involvement that is most common is optic nerve and facial nerve, which is followed by vestibulocochlear nerve. The features that are contradicting the diagnosis include the patient did not have any other systemic involvement, and the ESR of the patient is normal. Though sarcoidosis can have low glucose levels, but usually the glucose levels in sarcoid will not be less than 40. The patient had glucose levels consistently less than 40. Chest X-ray of the patient is normal. With young male and by temporal lobe involvement with patchy brainstem involvement and CSF OCTs being positive, possibility of multiple sclerosis was considered, but the CSF of the patient is favoring an infective etiology. There are conditions where the patient can have false positive brucella IgG. The conditions include syphilis, tuberculosis, infectious mononucleosis, HIV, and hepatitis infections. Those were ruled out in this patient with the workup. So with the clinical features, MRI finding, and CSF analysis, the possible diagnosis that we considered is neurobrucellosis, and we have started the patient on antibiotic therapy in the form of ceftriaxone 2 grams IV BD, rifampicin 600 mg OD, doxycycline 100 mg BD, and in view of cranial nerve involvement, dexamethasone was started for the patient. We have followed up the patient where the patient noted mild improvement in hearing in the right ear, and right now he is under close follow-up. The next line of management that we are considering in this patient is if we can find significant clinical improvement, we'll continue the antibiotics like ceftriaxone will be continued for about 6 weeks. Doxycycline and rifampicin will be continued for 12 weeks. Regarding the steroid therapy, there is no particular guidelines for steroid therapy, but steroids can be continued for about 2 to 6 weeks. If we don't find any significant clinical improvement, we'll go ahead with the PET of the patient, followed by biopsy. And the close differentials that we can consider in this patient is tuberculosis and sarcoidosis. So possibility of steroid trial or ATT trial can be done in this patient. Remote sensory neural hearing loss as a manifestation of neurobrucellosis. The immune mechanism behind these deceptive symptoms. Various theories have been proposed for this immune mechanism. A recent experimental evidence.
Kavya, you are going to discuss the theory also now only? Reshma will be doing that. Or even if you are doing, after the discussion, we should be going ahead with the theory part. Okay. I request the attendees to post their observations, queries, or any questions what they have so that it can be taken up. Kavya, you brought about brilliantly about the localization of the hearing loss and ataxia. So, few of the differentials what you told. One thing I just want to mention is, if you look into the oligoclonal bands positivity, it is not that OCB is there, it is multiple sclerosis. I think we should not live with that knowledge at all. OCB is not equivalent to multiple sclerosis. That is the first thing. And if you look at the possibilities of what are the reasons for OCB being positive, many other, even infections like HIV, measles, Lyme's also can cause. So we should be aware of both that it can be there. And among the differentials when you brought about for and against, one of the things is when we look at any white matter lesion which is there, it's not that all white matter is demyelination. So none of the white matter lesions except the left frontal, which was subcortical location, none of them were fitting into the criteria. They were not perpendicular to be classified as multiple. I think that also you should bring up in your negative differentials, what you brought about one topic also. Dr. Kirtika has asked you one question. While the localization was nuclear, it could also be UMN with LMN, temporal could also be involved.
Regarding the hearing disturbances, we considered nuclear and intranuclear. With other findings being so intraaxial involvement, brainstem localization were considered.
Dr. Arun is asking whether HSV PCR was done.
Yes, ma'am. CSF biofile was sent. It is negative, ma'am. In that HSV is done, it is negative.
So in the biofile, you'll have these viral, which could be one of them is HSV. So it was done. So do you have the follow-up of this patient? So what did you give the treatment? I think you did not mention about the treatment. What did you do?
We have mentioned, ma'am. Patient was started on ceftriaxone 2 grams IV BD and rifampicin 600 mg OD and doxycycline 100 mg BD. Along with the patient is having cranial nerve involvement, so we have started the patient on dexamethasone. We have actually called the patient. He is telling there is mild improvement in the right ear, ma'am. Initially, he was unable to hear anything in the right ear. Right now, he is able to hear mild sound in the right ear. So the patient is yet to come.
So you had the follow-up after how many days?
recently, ma'am, 1 week later.
Okay,
like,
this is a
after
very
starting
new
cancer.
case. This is a
Yes,
very
yes,
new case.
recently.
Okay, okay,
Yes, ma'am.
okay. So I think that answers Dr. Madhuri has asked for the repeat imaging. I think this is a very recent patient which they have presented. So still follow-up to be done. Dr. Madhuri has also asked about whether there was any family history or recurrent
No,
headache.
no, ma'am. No history of no family history and no history of any recurrent headaches or seizures in the family, ma'am.
What was the reason, Dr. Madhuri? If you can just type the reason for asking the question about the family history and everything. Anything specific you had in mind? If you can just put in the chat box. Thank you. MRI changes in the anterior lobe and the claustrum. I think anterior temporal lobe it was there. Whole it was involved bilaterally. Claustrum was not involved. I think the external capsule on the left side was involved. That is also a classical of CADASIL, but it was asymmetrical in the higher up. Usually, when the temporal poles. Okay. 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 Thanks, Nazir.
Ma'am, there are 3 slides which I would want Kavya to present. Can you please show lacunae, points to be discussed, and why we chose the case? Those three slides, if you can just show Kavya.
Yes.
Yes,
Leave
Reshma.
the literature part, show the...
Okay. There are certain lacunae in this case, ma'am. The patient never had history of fever, ma'am. It may be difficult to buy, but as such, fever is a very non-specific symptom. And also, we did not have any unequivocal evidence of brucella is still not available in this case. Remote neurobrucellosis may not have a serology in serum and CSF as expected. And one more lacunae is the patient is having only short follow-up. Longer follow-up is required to prove our hypothesis. Imaging findings do not fit into any particular pattern. Because
You can just go back. You can just go back to the lacunae. You are going to present all three, and then we are discussing.
No, ma'am, this is the only case we wanted to show, but why we chose this case, she'll just display in one slide, and then I'll probably talk about the discussion part. You can show why we chose this case, Kavya.
So we'll come across such similar cases in our clinical practice with ambiguity and having diagnostic and therapeutic challenges. Serology in such challenging cases may create more confusion with regarding to specificity and sensitivity. Approach to each case can be tailor-made, and it is very important to formulate a hypothesis and have a resilience to modify the same periodically to reach a diagnosis in retrospect. And these are the points that we want to discuss. Interpretation of serology in rare neuroinfection with immune-mediated neurological presentation. And as we are considering neurobrucellosis in this page, duration of therapy in case of inadequate response and duration of steroids. And what are the prognosis and prognosticating markers in sensory neural hearing loss in neurobrucellosis? And role of hearing rehabilitation in sensory neural hearing loss in neurobrucellosis.
Just go back to the lacunae slide. I think we should understand two things. One is systemic brucellosis, neurobrucellosis. Systemic brucellosis, you can have all these history of fever, weight loss, and many other things will be there. But in neurobrucellosis, if you actually review the literature or remember most of your cases of neurobrucellosis, you will not get your systemic symptoms. It is less than 25% of them that they will have systemic. But involvement of hearing is very classical. Sometimes up to 70 to 80% of them can have involvement of eight nerve in the neurobrucellosis. If you could, I don't know, you have showed one slide about the contrast that it was normal. If you can just go back and see whether there was the seventh, eighth, those complex, whether they were enhancing, because most of our patients, at least in our institute, we have found that they were enhancing with in cases of neurobrucellosis. I think that is one thing to be looked into. So it is not that all these neurobrucellosis will have systemic symptoms. We should remember that. And what were the other questions you had put in the lacunae?
only we have serum IgG positivity, ma'am. Only one value of serum IgG positivity is there, and we could not find other evidence of brucella. That is still not available in this patient. The follow-up is also required.
So, what are you saying? This is neurobrucellosis, or you're telling it's not neurobrucellosis? You're only contradicting your own thing. One thing is when you don't have adequate follow-up, then it becomes difficult to tell. So I think if you had an adequate follow-up response to treatment, that also is a clue that you have given the correct thing, because not all patients are PCR positive, and PCR positivity and culture is less than 10%, PCR is 20 to 30%. So most of them are antibody usually, and sometimes a twofold rise you have to do in the standard agglutination test. So that is a way to conclude that brucellosis is there and response to therapy. Okay. Imaging findings do not fit into any particular pattern. One thing is, you can again go back into the history only because of the temporal pole involvement about the history of whether there is. I think Dr. Reshma is typing. If you can just mute yourself. So you can just go back into the pedigree and see whether there is any because temporal pole is involved. Otherwise, supratentorially doesn't look like involvement of CADASIL or any genetic mediated disorders. And neurobrucellosis, I think, will have non-specific white matter changes or just a pile involvement with cranial enhancement, cranial neuropathy. So they will have the complex enhancement. It's only with time that they spread into the parenchyma. That is the other thing, whatever is there. And next slide. Why we chose this case? I think that Reshma will bring about, I think. Then the third one, interpretation of serology. I think you have two people who will bring about this discussion. I think we can bring these points for discussion after they present. Do we have anything from the chat box from the attendees? If nothing, we'll go to Reshma. Reshma, you can present. Because of the lack of time, we'll do it.
Kavya, can you just stop sharing? I'll just... Can I get some help from the digital team? I'm unable to share my screen. Can I...
It came in between and went, Reshma.
Is that visible, ma'am?
No. Asmita, she's not able to.
Kavya, you can help me. Otherwise, I'll quickly send this PPT to you. You can do it otherwise. I can read out, I think. I'll just share with Kavya otherwise.
It's fun now. You are sharing screen, Reshma.
I think it my case. This is a MacBook, so
Yeah, both the same size, but just open the PowerPoint.
yeah, the PowerPoint is open.
No, it's you have to go to the first slide.
I think. Am I visible?
The full screen.
Is this visible? Is this?
On the full screen. Yeah, the screen is visible, but not in the slideshow mode.
Is this okay?
Not coming out. It's still in editing mode.
Is this okay?
No,
Not coming out, ma'am. Still in editing mode, the PowerPoint is.
I think you have a update on top. That's the reason it's not allowing you, I think.
Sorry, ma'am.
There's a update column up there. I think that's not allowing you to screenshot.
Shall
And if possible, you
otherwise,
can share the
can I
screen as it is.
do that?
Yeah, you present it like this only, Reshma, in view of time.
Yeah.
Okay, ma'am. Sure. Okay, sure. Okay. Good evening, everyone. I would like to thank Netra ma'am for giving me this opportunity. Nizams, I mean, my team and my resident, Dr. Banu, and myself this opportunity. So without delaying, talking about our case, there is an entity called demyelinating steroid responsive neurobrucellosis. Does this entity exist or no? And then we'll discuss what were the handles we took from our case, from the history. In this particular patient, who's a young male, he presented with bilateral progressive sensory neural hearing loss with subtle cerebellar symptoms and no constitutional symptoms. So the tendency to think of inflammatory etiologies is very, very high. So the possibilities whenever we hear of a bilateral progressive sensory neural hearing loss in a young male, the tendency is to think about Susak and Cogan syndrome. But in this particular case, there are no vestibular symptoms, no encephalopathy. So one more thing to notice, in Susak and Cogan, the typical triad may not happen, and the cochlear symptoms may precede the vestibular or the ocular symptoms or encephalopathy much before. So the tendency in the absence of fever is to always think about an inflammatory etiology like Susak and Cogan. And whenever we have cerebellar features and brainstem being considered as an anatomical localization, the next possibility would be a Neuro-Behçet's or Sjogren's syndrome. But in this particular case, we didn't have any other symptoms suggestive of either isolated Neuro-Behçet's or isolated neurological manifestations of Sjogren's. And sarcoid in this particular case can be a possibility, but meningeal signs are usually present. An important history in this particular case is animal handling. More about animal handling will be explained by my co-panelist, Dr. Bhanu, after my presentation. So animal handling history is extremely important whenever we come across a patient presenting with a progressive sensory neural hearing loss. And what were the handles we took from examination and investigations? Well, bilateral sensory neural hearing loss and unequivocal evidence of cerebellar involvement with spastic dysarthria was there. So we know that there is some patchy distribution of a lesion which is giving rise to all these symptoms. So even more towards a diagnosis of an inflammatory etiology. There were no active markers or infection or inflammation in our case, and CSF was one of the most important investigation we took as a main handle. We had a lymphocytic predominant pleocytosis with very high protein and a low sugar. As Kavya has shown us that 3 different time points had 3 different CSF values, and all the 3 times what we consistently observed was there was a lymphocytic pleocytosis, but sugar, that is the blood glucose level in the CSF was always less than 40 and the protein was always above 140. And then CSF OCB, we always need to think out of box. Like Madam has already highlighted that whenever there is CSF OCB, and now that in the criteria we have given in the latest McDonald's criteria, the importance of OCB has raised to an extent that we are taking it as a criterion for dissemination in time. But CSF OCB means there is intrathecal synthesis of immunoglobulins. That means there is some problem in there is some kind of an insult, and that has given rise to an inflammation. And then there is a blood-brain barrier disruption where the B cells are migrating into the CSF, and there is a CSF synthesis of immunoglobulins, and these OCBs can be a manifestation of that. So CSF OCBs can be seen in many other neuroinflammatory and neuroinfective etiologies. So we should never get carried away when we look at the CSF OCB picture. This case was referred to me as a suspected multiple sclerosis. So kindly do the needful, and patient received 1 dose of pulse steroid and he had come to me. So this was the main point which was taken as a handle by someone else to consider it as MS. So we always need to think out of box whenever the CSF is giving us very strong handles with a suspicion of infection. And in this particular patient, MRI did show some white matter hyperintensities in a very patchy distribution, and CIS-3D image did not show any affection of the 8th nerve. I'm emphasizing on this because whenever there's a cranial nerve involvement, we need to ask for special sequences like CIS-3D, because Cogan syndrome, which is very common syndrome where we can have a vestibulocochlear manifestation, CIS-3D is an important sequence which we need to ask, because in acute conditions and in chronic relapses, it helps us by looking at the various hyperintensities in the labyrinth semicircular canal, their size, and their hyperintensities on the MRI. So in this patient, none of it was there, but the patient did have some demyelination at various locations in the brain. And IgG Brucella ELISA positivity. How important is this on one occasion? Is it really important or no? I think a lot of light will be thrown on this by my co-panelist, Dr. Bhanu. And Brucella culture usually requires about 5 days to 9 days on an average. It has been 10 days since the discharge of the patient. And we have discussed with our microbiologists, they said that nothing has grown. But what they usually do is they will wait for 21 days maximum. And after that, they will ask the clinician for a bone marrow culture, because that is supposed to be the most sensitive. Whatever said and done, the Brucella culture being 100% specific, but the sensitivity is only 15 to 30% in CSF and 20 to 80% in the serum. So the culture sensitivity is very, very low. We have sent both serum and CSF. So far, there has been no growth, and it is unlikely after 10 days to have a growth of Brucella in the serum and CSF. If the clinical suspicion is very high in systemic brucellosis, we can always consider to go ahead and do a bone marrow culture of Brucella. And some unique features of neurobrucellosis. Constitutional symptoms which are highlighted as a feature of neurobrucellosis may never be there in neurobrucella, because systemic brucellosis is a different entity and neurobrucellosis is a unique entity. And imaging patterns are of 3 types: inflammatory, contrast enhancing, white matter demyelinating lesions, and vascular. I have mentioned 2 references here which are good reads for all of us to know more about the MRI patterns of neurobrucella. So whenever we are looking at neurobrucella, these 3 patterns have to be considered. I have adapted this from, this is the reference from American Journal of Neuroradiology, and they have shown the first pattern is a contrast enhancing pattern. As we can see here, we have the pachymeningeal and leptomeningeal enhancement when the patient presented with symptoms of headache and lymphomeningitis. And after the treatment, as we can see, significant resolution is there in the image which is below on the right side. And on the left side, top CT, we can see that there is small hemorrhage in the thalamic region on the left side, which is a vascular manifestation of neurobrucellosis. And what we see in this image is the white matter affection causing demyelination. And there is a specific predilection of involving the arcuate fibers. That is the predilection of neurobrucellosis. So this is the subcortical white matter, periventricular white matter affection, which is a demyelinating radiological phenotype of neurobrucellosis. And this, the intense contrast enhancement, is the inflammatory contrast enhancement, the top 3 images. And post the treatment, as we can see, remarkable responses there. And in this CT, we can see the vascular manifestation, which is in the form of a hemorrhagic stroke. Sometimes we can even have ischemic stroke. We did have a patient with systemic neurobrucellosis presenting as watershed infarcts in the ICA territory. We treated her with antibiotics, and the patient had near complete recovery, and she is 8 months into follow-up with us, and she's doing exceptionally well. But these are all the images which I have taken from this reference by M. Walid et al. From AJNR. And serology can be erratic in chronic neurobrucellosis, because serology can change with the acute or the chronic phase is one thing. Serology can change with the manifestation, and the type of manifestation of brucellosis depends upon the endemicity and many other things. So serology, what to give importance, Dr. Bhanu will be talking more about it. And this is an image which is showing the sensitivity specificity patterns. I'll display this image when Dr. Bhanu will be talking about it. There is a special emphasis which we want to talk about Brucella capped and other cultures. So Treatment in neurobrucellosis depends on whether it is an acute infection, chronic infection, whether it is an active infection and inactive infection. Conventionally, by traditional teaching and from the literature, we know that we give injection ceftriaxone 2 grams IV BD for 6 weeks, and we give rifampicin and doxycycline. 600 mg OD of rifampicin is given for 6 weeks conventionally, doxycycline 100 mg twice a day for 6 weeks. And role of steroids, we do not have any validated studies in neurobrucellosis to recommend a particular guideline that this much dose of steroid for this much duration can improve. Whatever literature we have, it is from anecdotal case reports in demyelinating and inflammatory phenotypes of neurobrucellosis. So they have how long to treat? Well, neurobrucellosis is unique because 6 weeks of treatment may not be enough. We need to treat the patient as long as 6 to 12 months. And steroids, from the available anecdotal case reports, they say that for 6 to 12 weeks you may treat. And how long to treat? This question is a common one. And the treatment usually is recommended by various authors that till the CSF cellularity, proteins and glucose are normalized. And if you are looking at sensory neural hearing loss and the disappearance of white matter, that may not happen because the white matter demyelinating features and affection of white matter on MRI may remain or persist forever. All we are looking at is the clinical improvement and the CSF. So CSF can be taken as a monitoring tool for us when we are treating patients with neurobrucellosis. Prognosis, from whatever literature is available, there are two phenotypes or clinical presentations of neurobrucellosis where the prognosis is very poor. One is sensory neural hearing loss and the other one is myelopathy. What is the treatment option for patients presenting with sensory neural hearing loss is the hearing rehabilitation is number one. Cochlear implantation in patients who are having affection of cochlear hair cells and early retrocochlear lesions can have improvement with cochlear implantation. There are 3 discrete anecdotal case reports where 6 or 7 patients have been treated with cochlear implantation, and they have shown that patients are improving with the cochlear implantation. So we should never miss out on offering cochlear implantation as a treatment option for our patients when they present with sensory neural hearing loss and neurobrucellosis. With this clinical context, IgG positivity, we feel it's neurobrucellosis and we are hopeful that the patient will recover, and we are yet to follow up. We wanted to present this case because we wanted to take more inputs from all the esteemed panelists and learned audiences. Thank you.
Dr. Banu is presenting anything, Reshma?
Ma'am, he will give us some insights on neurobrucellosis, and I'll display the sensitivity slides of all the various tests used in brucellosis. Dr. Banu, are you there?
Yes. Good evening, everyone. So I'll just briefly explain few things. So regarding the brucella, it is one of the commonest worldwide zoonotic disease, and India is also endemic area, but it occurs in bits and pieces. Like it's common in Himachal Pradesh, West Bengal, and also the mid central India. So there is no clear cut how much is the prevalence, but it is a quite common thing and one of the common zoonotic disease. How it spreads? Usually, what we know is a unpasteurized milk from the animal, cattle, sheep, goat, and it gets to the digestive tract, then bacteremia, then seeded into everywhere, and it goes into inside the cell, became dormant like TB, and it manifests when the immunity comes down. This is a common presentation. There is another type of presentation where rarely we see based on the exposure to the animals. So when they are handling the animals, even if there is a skin contact, there is a small abrasion. Butchers, farmers who handle the animal carcasses, they have a high risk of spreading, and this form of spread is associated with a very poor prognosis. So this is how it spreads after that. Once the immunity comes down, it produces an inflammatory response, evades the immunity because it's inside the cell. It's a great mimicker. The presentation usually like a TB. There are 2 different presentations, acute to subacute form, where there is an extensive systemic involvement, bacteremia, osteoarticular involvement. It can cause neural involvement. In that case, most of our cultures will be positive. Patient will have an extensive systemic symptoms hepatosplenomegaly, all those things will be there. There's a different form which we have seen in our case. It's a chronic phase where cultures may not be positive. What we have is a past exposure to the infection. That is, the serology or PCR might be positive. In this case, the main, like ma'am said, there won't be a fever presentation or systemic symptoms. It's a localized CNS disease. There are various CNS forms. Even it can present with a meningitis, which is commonest, meningoencephalitis, myelitis, and specifically a bilateral eighth cranial nerve involvement, which we have seen in our patients as a chronic lymphocytic meningitis, along with bilateral eighth cranial nerve involvement. There are multiple demyelinating lesions in the cortical, subcortical, brainstem, and cerebellar involvement, which is not clearly fitting into any of the inflammatory pathology, not very clear. So the CSF picture we can see, it is a lymphocytic, low glucose and high protein, which is a characteristic of a significant chronic inflammation. What we routinely expect is a tuberculosis or a fungal meningitis like a cryptococcal meningitis. In tuberculosis, it's a great mimicker, so we cannot completely rule out it anyway. CSF culture positivity and CSF expert positivity from the tuberculosis is very low. Even if it is negative in a certain clinical context, we need to treat empirically. Here, the eighth cranial involvement is more in favor of a brucellosis. And in the diagnosis part, the serology will always help. So there should be evidence of infection. In the serology, what we used previously have a standard tube agglutination test. Our Rose Bengal test was phased out, so ran standard tube agglutination test, which has fairly sensitive. It's around 96% from the serum. But the CSF sensitivity is pretty low as 20 to 40%. We may miss most of the times. That's why many of the recommendations suggested to do two different types of serology tests from the serum. If it is positive in the CSF, it has a high positive predictive value. And at the same time, considering the endemic area in India, low-level positivity in the serology is quite common. It represents the past infection, not the actual neurobrucellosis. In our case, the titers are pretty high. 22 is the cutoff. What we have is around 90. So this represents there is high positivity, probably an active infection, like we discussed. So the fourfold or twofold rise in titers will have a greater significance. In the serology part, there is a newer form, ELISA is available, which is quite sensitive, quite as sensitive as standard tube agglutination, which is messy and difficult to do. The differentiating factors are, in a standard tube agglutination test, like we have two different species, Brucella abortus, Brucella melitensis. In India, from the cattle, most commonly Brucella abortus that causes. So in this standard agglutination test, we can detect the two antibodies separately, and we can get the titers. And the chances of false negativity is low in these patients. Whereas ELISA, we have only common tests, and there are various different types of antigens and different types of ELISA tests. The standardization is difficult. So Brucella septicus, which is a capture ELISA, which seems to be a more sensitive ELISA test than the other tests. So overall, serology might help in a supportive way. So how do we diagnose neurobrucellosis? Characteristic clinical symptoms and signs. Presence of serology, PCR. Just a minute. Serology, PCR, and the cultures. One of them positivity. And if there is a history of animal exposure, these are the three clinching points. If there is a significant response to treatment, that confirms a neurobrucellosis. This is one of the diagnostic criteria, but there is no well-standard criteria to confirm the brucellosis. This is what we can consider. Yes, ma'am.
Yeah, we can have little discussion also, because we just have 2 more minutes to wind up. Just 1 more minute is the reason. Anything else? Take home message would you people want to give before we try to wind up?
We just wanted to tell that neuro brucellosis is an infection which can remotely give rise to neurological manifestation because of an immune mechanism. And considering steroids in these kind of phenotypes should be always on a priority whenever a treating clinician is looking at these kind of manifestations in the absence of constitutional symptoms with a remote neurobrucellosis. That is the take home we wanted to tell, ma'am. And I think someone asked about how common is neurobrucellosis without headache. Neurobrucellosis without headache and isolated SNH involvement is very much known. That is a very common phenotype, and headache is present in between 50 to 60% of the patients. So it is not always a necessary clinical feature along with symptoms like sensory neural hearing loss.
Thank you, Reshma, Dr. Banu, and Dr. Kavya for bringing out this case of infection. One of the things just to mention is most of the time when we make a diagnosis of neurobrucellosis, we will not have all the culture and PCR, which is more specific. It is only about these antibody tests and agglutination test and the clinical. So just like how you don't have a biomarker in demyelinating diseases, this is also, though there is a biomarker, we'll have to take the clinical consideration and then make a diagnosis. And just to add about the headache part, brucella is not something which presents with raised ICT or a meningitis-like illness always. You can have a chronic degenerative condition also. You had patients with Parkinsonism, but they also had little bit of hearing loss. Hearing loss is one thing which is there, it's quite common, and that should always ring your bell because we are from endemic place. India, Middle East, Iraq, Iran, Turkey, these are all quite endemic for brucella. So we should remember that, and we should always test it whenever there is a possibility of pleocytosis or raised protein in CSF, which gives you a clue about the infective etiology. I think in view of the lack of time, I would like to thank everyone involved, both the teams. Thanks, Dr. Anuja and Dr. Vaishnavi from KIMS Hyderabad, and Kavya, Reshma, and Bhanu from Nizams. And I also thank all the attendees who have participated in today's program, and request more participation from the attendees for a better discussion. And thanks to the digital team and Asmita for making a smooth transition through this webinar. Thank you, IAM, for giving us this opportunity. Thank you, everyone.
Thank
Bye.
you.
Thank you, ma'am.
Thank you.
Bye, Roma.